Good morning and welcome to our monthly podcast. I'm Samir Mehta, your moderator. This is session number 199. We are often asked how do we manage all these cases logistically. So today is an example when you get challenges which become multifold. We had a previously scheduled patient who became unwell because of a flu, and we have replaced within the last few hours a comparable case, another left main bifurcating case. And with this introduction, how we deal with the numerous aspects of coordination and logistics, let me take you to the cath lab. Samin, Anu, I know what an incredible effort for the team and for the patient.
Yeah, good morning. Just myself here, and we have Dr. Sharma. And with regards to the fellows, we have Bharat Raj, Prithvi, and nurses, we have Ryan, and we have Jacob. Then technician is Asif and Nino, and of course our imaging cannot be without anybody but Kiski, who actually is now in almost every live case that is happening except the structural and peripheral. He's in every live case that is happening from Mount Sinai. Okay, Dr.
Yeah.
Sharma
So
finished.
with that note, actually, as you said, we always have, it's called well-run, well-oiled machine. So key is that case left main, that is what we wanted to teach, and happened to be the patient got sick. But then we have another one in the backyard, which are the patient also left main. Only difference is that was a trifurcation, which we wanted to show bifurcation and then mini crush, and hopefully the drug coated balloon for the third branch. But then now we have the left main bifurcation, and happen to be a patient of Dr. Nitin Barman, my associate, who is the director of the cath lab at St. Luke's, Mount Sinai, Morningside. People still call St. Luke's, but so even yesterday they were all talking about the patient at St. Luke's. But yes, his patient left main bifurcation, even more challenging than the first one because of the angiogram we will just show. But we really want to thank Nitin for this excellent kind of case, educational case which have been provided.
And Nitin has been the moderator for our,
Imaging.
Yeah, and imaging has really taken off with what we say is rocket fuel.
Yeah.
Just outstanding logistics. I don't even know how it was all managed.
All right. So Anu, show it first. We want to show the case, and then we'll go to it now.
So we can show the angiogram.
Yeah. Let's show the angiogram first.
da.
Okay. Show the angio. Good.
So EDP was actually 10 normal
whatever you
EF.
want.
We are hydrating a lot, and this is where we have the right coronary artery moderate disease of the RCA, and this is where with the left vein. So I know this is a very old way of showing tram track calcium right from the left vein all the way the prox to mid LAD and circumflex, and this is where we are.
Oh, wow.
So significant left vein,
Amazing.
ostial.
Anu, this is my first look and that was my reaction. Wow.
Yeah, and this is where the cranial picture. So there is significant mid LAD. There's a moderate size diagonal that is also involved here. Yeah.
Just the circumflex is as challenging as that entire previous case.
Yeah. So our plan would be that we'll go to the via the circumflex first with our usual fielder fine cross, and if it goes okay, we will try, depending on if the fine cross crosses, then we will go with the rotational atherectomy, which we have ready. Then after that, goal is to wire both the vessel, we'll image both the vessel, and then probably we can do IVL of the left main to LAD, if that's what the plan is.
And in the clinical history point of view, it's a little younger patient than the previous one, who is 82. This is 72, 10 years younger, and presented with angina and positive stress test in the past, was waiting for surgery, discharge, and now came back with a non-QA, non-STEMI. And that is why this patient now, after heart team discussion, surgeon said, patient having MI, you guys take care of this patient as a PCI. So this is how, if we can briefly just show our presentation mode, if we can show the slide. So a little different, but we are just about ready. This is our still remain accreditation, can get a CME as shown here. and of course myself, Anu, no, and of course Samir, all are no different disclosures. Just 1 second, you'll go. And these are our supporters. And so basically, as I said, this is a little different patient, but the concept remains. Instead of trifurcation, it's a bifurcation. But up to date, the patient after heart team discussion and non-STEMI is appropriate. And so with that note, we are ready, Anu. Okay, go back to angio now. Okay, what wire you are using? And
this is a fielder.
Okay. And it's a run through, or I mean the fine cross, or
yeah, fine cross.
I see.
And that angulation and the calcification is quite challenging.
Yeah.
And that's a 7 French guide, I'm assuming.
Yes. Because our goal will be ultimately to do a mini crash. This will prolapse.
Yeah.
Otherwise, you can always use a little stiffer wire now at this point. Once you start making there, which is our Gaia 2 is usually the first one, although one many times uses Miracle 6. But if the fielder does not make turn because you need little stiffness, then the Gaia 2 is my next wire. And here is the fielder where this has been advanced. So see, unless you have a body, it will prolapse. That's a usual thing.
I was thinking absolutely the reverse. I thought maybe you could even consider a whisper wire here. But you may be exactly right. You need more
little body to penetrate. Yeah. So it came to until that aneurysmal segment.
Excellent question, Samin. To start with, the Dr. Ravi Kiran, any possibility that you're dealing with the left circumflex calcific nodule?
Well, let's go through. We are all ready with the IVUS and Kiski on angiogram. You think it's a nodule?
Yeah, looks like a protruding based on the angio, highly posterior. But
to me, I think it looks like severe calcific rock, circular plus aneurysm there. So that's what. But we will have the answer there.
Yep.
Very soon. Only thing is, if we cannot get in, that do you want to that whether the IVUS will go? But remember, many of the trials now what they're doing is opening the tight lesion with a 2O balloon, do the imaging, and then randomize the patients. The OCT FDA trial showed that they want to open the lesion with a 2O, then do OCT, and then randomize.
Get me the Miracle 3.
Okay, Miracle 3.
We have 6. 6 is okay.
6.
Too.
We have 6. I don't think we carry 3.
We have 3 also.
Oh, wow.
This is just to have a thing. Is you need a
Gaia 2.
Gaia 2.
No. Tell me what you want. I mean, I want you to do. I'm saying I would go with the Gaia, but if you want to go to Miracle 3 or 6, we have both of them.
Get the Miracle 6.
Miracle 6, yeah. You need a little extra body.
No, I'm talking about tip load. The thing is.
Yeah, Samir is saying the whisper. You want to try whisper? No, I don't think the whisper is. Look, this is a big chunk of calcium, a big rock, whether it's a nodule versus what. Yeah, you want to make a curve first? So what did you decide?
I was focused more towards the tortuosity, but you're exactly right. I mean, let's very
the
tricky
guy
lesion.
also ready. Yeah.
Keep that wire separate on the table. We may use it later. We have venture also.
Yes, sir. No. We don't need. It's not the venture.
No, we just have. I always say that difficult case get all the things available in the room. Doesn't have to. You don't have to open them. But so that not every time when you're asking for their looking go to a few some other place. So I would always say you have to be just keep them.
Get it, but don't open it.
Don't open it. Yeah. You want to see little die? Where you are?
Okay.
No, the view is very good. As you know, the angulated catheter venture has been discontinued long time ago. We bought about 100 of them. I think we left about 15 not available. Otherwise, you can go Supercross. Those still available, which is 90, 120, even 180 or 145, I think. But we carry only 90 and 120, which is 60, 90. Let's see 1 second.
No, you want Confianza or Gaia?
No, this one is Gaia 3.
No, no, no.
Gaia 3.
Please take a
Okay.
second. Okay, get the Gaia.
No, first Gaia before Confianza.
Okay, get the Gaia.
Gaia 3. And I'll make an additional slight curve, proximally.
I have the fighter ready also, okay?
It's no good. NG. This way don't need.
Garbage, yeah.
Okay, just a little proximal band. So there's always a very tip, a 1 millimeter band at the tip, but then you make about 3-4 millimeters slightly. So you point down, and then you have the fighter also. But yeah.
Samin, tell me more about the fighter wire. I've not used it or known about it.
Yeah. So
Yeah, fighter
makes
wire
sense.
is by Boston.
Yeah.
If Andrew is there, he can bring you the picture. It has it's tapered to the tip of 0.009. But
guide is out.
yeah, no, guide is okay. Okay, wait, this came out.
You need a full guide support in this one. Yeah.
Now there.
Yeah.
Good.
Good. Get a balloon pump ready.
Absolutely.
I don't know if our viewers heard
You
your.
understand SSY was the thing, means you needed a larger curve there. Okay, there. Now.
I mean, just for the audience to learn from the masters here, I heard you almost whisper, keep a balloon pump ready. I think that is such a useful teaching part. I mean, this vessel, if the circ was going to shut down, you will need everything, all decks on hand.
That's absolutely
all decks
correct.
on hand.
So same thing, that you need to be prepared
completely,
for all the
completely.
You see, it's not even making a turn because there's a shorter tip, and then risking something to go wrong.
What do you need?
Question. What else? No,
Which
you
one
threw it out. I wanted to change the curve.
No, but you need Confianza?
Yeah, Confianza 9.
Okay, let's make a turn.
No, you threw out that Gaia?
Yes, if you need, you get a new one.
Get us.
And show the what curve you are making.
Nothing.
Yeah. We can concentrate on that. Show on the top ceiling. Yeah.
Yeah, excellent job, Philip.
Yep.
Exactly good. Right. The
Venture
reason
in nearby,
to
right?
have the ceiling camera.
What are we have?
And all that may cost more.
Yeah. Or then 120 here. Let's see. Good.
Fighter is ready, and also get a. I don't know. You think laser may be needed?
As Samir, you pointed out that this circumflex is more complex than the trifurcation.
Look, my immediate reaction when I saw was, wow. I mean, I am very, very impressed with the severity and it's a very truly complex origin in the ostium. I mean, it's got calcification, a terrible location, angulation.
Fielder XT. You know, this may cause trouble in the left main. So stiff.
Yeah, I mean, I as soon as I saw that severe angulation, I mean, my go-to wire has always been Whisper for angulated lesions. It does what a challenging case.
X. Show me. Yeah.
I mean, to look at the complexity, we've already tried half a dozen wires here.
Yeah.
Just about the workhouse are half the wires which traditionally we would use for a CTO.
That is correct. We have over the wire venture or monorail. Then we go with the over the wire. If this does not, then we go over wire. So basically what could happen is venture by making a curve on the opposite wall. It will give us a little extra support, or going with the 120 supercross.
This has looked the most promising.
Even Fielder was okay, but didn't
Yeah.
have the stiffness.
No, they don't have the body. I know a lot of people are like Japanese are very big on this Fielder XTA, XTR, and all those things. To me, they're just very flimsy. They're based on the micro channel. This is not the micro channel. This is a macro channel, but all calcific track.
What do you have?
No, laser later. First we have to cross, my friend. Yeah, 1 second. Once you make further.
Not so sure
None
laser
of them
would be,
is,
it's a angulated segment there. Somebody
take
has
1 second.
mentioned again a role of double lumen microcatheter. I would keep these double lumens away from here. It's but
Yeah, a lot of people believe it. Because believe me, we tried few of them.
yeah.
Never worked out. To us, best is go with the venture or supercross 120.
Look, also, I mean, this is you shut that circ off by these aggressive maneuvers. You'll have a
See a little bit.
oh wow.
No, this is not going to work. Too flimsy.
Oh.
Yeah. I think we need a over the wire venture, and then we go with a stiffer wire there.
No, it's not going to happen. Venture is not the best.
Mango?
No.
Hmm?
Yeah,
It's
the
not-
pilot,
maybe
pilot
maybe
200.
maybe
Throw that
even a
away.
more severe bend on the wire.
No, that we did few of them,
Yeah.
but I think it's the same thing. It's not engaging right there because of calcium deflecting from there. And then what you wanted? Which wire you wanted? The pilot 200 or pilot?
Pilot 200. The other one, we have to just do the left main to LED first.
No, we can always do, many times we have seen that you put try to crack the plaque of the left main, and that will allow your wire to drop down. So what we do in that situation, put both the wires into the
No,
LED.
I'm not
and
saying
then
you have to do
cut,
rota
then
of the
cut.
first one.
No,
Rota
first
of
you
the
do a
LED.
cutting, and then you try to put a wire into the circ, because circ once closes, it's so difficult. I would give every try to keep the circ, try for the circ first, and before going further, I think we do use the venture. I think venture has a very good chance in this case to work through.
Why I'm saying no venture is significant left main disease. The venture is not going to be, easy to manipulate at that level.
Or
Yeah, no, yeah. Or supercross. One of them.
I
You want a supercross 120?
I mean, listen, we can try
Get
all
a
that,
exchange
but
length fielder and supercross 120. Yeah,
no,
let's
the
get that.
supercross does not work.
Yeah, tell me, Samir.
No, I'm urging the viewers to listen very carefully to your conversations there. There is so much wisdom in the way you are proceeding here. So I'll also keep quiet and let that. A few people have mentioned that there may not be room enough there for a venture, but that's what Anu was mentioning. But
I think we have to do rota of the left main to LED.
After
yeah,
your
but you
angulated
take,
catheter
right.
it fails.
You
Make
do
it up. Yeah, supercross. 1 second, yeah. Little better. What is this wire? Tell them. No.
This is a pilot 200.
Andrew is there to show those on the side.
Pilot 200.
Just show on the side that your fighter and the pilot. What is this? Good. And get the filter wire exchange length.
Okay, give that one. It's making the angle but not making that turn.
Yeah.
Before we go to that one, give me a Gaia again.
3.
Let me do a stiffer,
Okay.
bigger.
Gaia
curve.
3. New Gaia 3.
Andrew, thank you for putting up the slide there. That's the fighter wire, which I was not familiar with, and a lovely picture.
We have used
exactly.
it once. We have used it once
In the
one
case?
of the
Yeah.
one of the ones.
No.
No.
You have it there.
Gaia. 3, 2.
3. You need 3.
And then where's the
Pull back.
okay wire? Where's the wire? Then oh no. Oh God, this is
Make a bigger curve on that.
may not go. Okay.
What a amazing educational case. Just and I'm still the coordination which would have been needed to replace a case.
In the end, put a torquer. Want me to show it?
Bet you that protruding lesion just continues to deflect the wire away from the circumflex lumen.
So I don't want to be too aggressive. If we have any issue with the plaque in the left main, then
Put a torquer on this. Oh, good.
see the stiffer wires are not even making a turn into the circle.
Right.
So take that out. We are ready with the Supercross 120 with the filter wire.
Okay.
Take that out.
That's what you want.
Guys, hold it there. And we need this. We may need Gaia 3. Good. Go.
No, that Gaia 3, we have to change the curve.
It's good, all right?
No, it's not.
But
The curve is not
take
the
the Gaia
best.
3 out. Yeah.
The Supercross 120 is over the wire system?
Yeah.
That makes it even
You can
more
show the
challenging.
Supercross also.
Yeah,
Andrew.
amazing. This is unreal, Anu. This is Andrew on demand here. Whatever you urge, he's able to immediately put up the fantastic, Andrew. Excellent job.
Yeah, the KTT team.
Yeah,
One second.
just increases the educational value of the.
1 second. This one very difficult, so we need a little torquer support to even go to the LED. The only problem is with the compared to venture with the 120. I mean with the Supercross. Yeah, go. Advancing the device is very difficult.
Now, Samin, would it help to, let's say, put a wire down the LED and then put a kind of a parallel, hoping that.
No, unless we do.
Okay,
1 second.
this is very promising. This is very promising.
No.
Go.
Why did you have? Why you have a long wire? Should have a
Exchange
smaller
length
wire.
is always exchange length with
No.
this. Yeah. Here we can try our Gaia 3. Now we have it. Right, guys?
No,
bring
we
it.
need a new one.
Okay, new Gaia 3 without any extra tip.
Okay, hold on.
Yeah, so far so
no,
good.
No, 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 no.
No, that's
Maybe
okay.
It has
subintimal.
to.
No, that's
it
okay.
is a-
Subintimal is all right. Yeah, go. As long as it goes distally, we are not worried about the subintimal. As long as you can get into the lumen. You need torquer to move. Torquer again. Remember this?
No, I cannot work with
With
the torque.
120 and calcium and no, it will not go yet. It will not go. Your wire need a little more.
No, the thing is, it is at the
Yeah.
base, you need to deflect it.
Yeah. You need a stiffer, but try a little more with this.
Now die there. Are we in the
Yep,
lumen?
so far so good. And take a little picture. Yeah, so a little
It's
pull.
subintimal.
Yeah, I know, little pull, that's fine.
Subintimal.
Yeah.
I'm telling you, if this was a shorter wire, probably would have gone.
Oh, but you can put a shorter fielder. We have a shorter fielder. Fielder 180, we have ready. It was there on the table. Or we want to go to GAA 3. Correct. The tip is correct. Now we just need a little stiffer wire. Even subintimal goes to distal lumen. That's all we need.
Get us.
GAA 3, new GAA 3, right? What
They
do you want?
wanted, okay, give whisper. We tried
Okay,
everything.
let's try the
Get
whisper. Yeah. Let's get the whisper Jindabad.
The super cross has that's a very nice place where it has been placed. Just that it's a double angulation, both.
Double angulation and
120.
aneurysm.
Yeah. Just and calcification. Look, I go back to my immediate reaction when I saw it. And we were concerned. Last night I was thinking, that trifurcating case also had a challenging origin of the LAD, but nothing like this.
No. Their decision would have been that what you do for the Ramus. That was our plan was mini crush of the LAD sir and
Right.
Ramus. So that will be done some other day, maybe not for this. We CCC live maybe some other time.
I mean, it's more related to that case, but I was a little surprised looking at how there was a trifurcating lesion, but probably it had something to do with the angle, the calcification. The Stent score on that patient was 65.
Yeah, very high. And that patient Kath was done almost a month ago, and patient continues to. Finally, surgeons, there are sometimes difficulty in making appointments. The surgeon finally made the appointment, and then they said, oh, because of age, 84, should go for PCI. So by and large, I can tell you, and very good for our surgical team here. So if anybody is more than 80, and if we can do PCI safely, they will go with that. So now what we'll do, AK, bring back the supercross in the body, into the guide, put a wire into the LED, and then only it will go back. Yeah. Because what happens is as soon as you take the wire out, the tip of that completely bends.
I think 120 was not the right choice. Okay, anyway. Maybe 90.
No, just whisper is too soft. You need a stronger wire.
Body.
Yeah, this is the body of the, You want to just go to run through then?
No.
You never know.
You need a
Go run
stiffer.
through. Try the run through first. Since we have it.
No, this 120 is not helping us now. It did it first time, but now give me I did a curve.
Yeah. The other question is,
You want a miracle again?
Yeah, supercross 90?
Yeah, probably 90 because 120 is not doing. I'm telling you, we have to do rot of the thing to the other one.
So we can get 1.75 per rota anyway, ready if you want.
Yeah.
The chorus back for the dual lumen.
Yeah. No, but I can tell you the dual lumen is basically just telling you on the side. You cannot have a better support than what we have.
Supercross.
Yeah,
with this
supercross. Yeah, definitely.
Very,
Yeah. 1 second.
Anu, excellent technique. There we go.
That's it.
Bingo. Wow.
Nice.
This is the Gayatri, right?
No. Run through.
Run
Fantastic.
through. See, I said run through.
Just
Run through. Run through and 120. Sharma's prediction.
Anu,
Could
just
be your
the,
prediction, but the hands have to
I know,
work.
but
look,
it's
it's a
strategy.
combination of all
Strategy
it.
of 120. No, of course, AK's hand, no question on that. But I'm just saying,
And
now,
everything was done without a torquer.
the only thing is the people are talking about the dual lumen. I can tell you when this angulated dual lumen will not work. 100%.
Okay,
I
get
know
us the rotawire.
What I hope the viewers watched was how you were able to direct the supercross back towards the circ.
Fluoro.
I mean, you had advanced it more towards the LAD, then withdrawn it, and just excellent job. And
Yeah, hold it. This one too. Now,
the
only problem will be taking
biggest challenge is cross. That doesn't mean that the case from here is
No, but now,
straightforward.
but now taken everything together, 1.5
Yes.
bar, right?
Yeah,
1.5 bar. No road, no IVUS yet. We need to open a little bit. Nothing will make a turn. So we'll do a 1.5. Now,
Wait.
also just want to say, very difficult now to take the 120 out.
Yeah.
Because many times the wire will come with it.
That's the Rotablator.
Yeah. Good.
Anu, just
Hold it.
fantastic skills.
Yeah.
Outstanding job.
But to me, what we learned from this case, clearly, skillful wiring is very important. But at the same time, once it is not making any turn, that you need an angulated catheter. There are some other angulated catheter coming in the market now. What was the other? There is a third angulated catheter. We had it.
Andrew, any
There's
other
one more.
angulated catheter is
There's
asking?
one more beside because venture is gone. Yeah. So key is angulated catheter is the one we go a little early. Rather, see this now? Okay, I had to walk slowly here.
Yeah.
Yeah, Ninja. Exactly. Sweat Ninja. It's
Do you
available.
have the picture of that?
Yeah.
No, but
But
it's
Sweat
not, I'm
Ninja.
not
Also,
sure.
that's available.
Ask Kiski. Kiski, is it available in America?
No, it's available in India. Not in America.
Huh?
No,
It's
not in America. I know. It's available only in India. Okay, you get a 3O balloon ready?
We have,
Yeah.
no, not 20. You
Yeah,
want 20?
Yeah,
15
20.
is good.
Yeah, or 15. If you have 15, even better. Okay, where is the run-through wire? Make sure, guys, we'll going to need it for LED quickly. Okay. Yeah, good. Yeah, 3 or 15. Take it. All right. Get Mr. Clip. Okay. Balloon ready, keep it on the table. We don't know. Balloon should be ready. Always just say that whatever balloon you are going to use should be ready on the table. This we keep emphasizing it all the time because if there is a perf happens, even 20 seconds looking for the balloon will be too late. Yeah.
Okay, try the thing.
Yep. Ready?
Yeah.
Good.
Okay.
Go. And look for a 3.5 cutting balloon also.
No, we have IVL.
Okay. All right. Rotatripsy. Although shortcut trial said that after rota IVL versus cutting balloon, no difference except lower price. If you don't use the rota, then IVL is better than cutting balloon. But if you use the rota, then IVL did not show any additional advantage in the shortcut, but that was the short-term data. Only in-house, 30-day.
Look at the wire bias
yeah,
already.
Yeah, that's okay. Pull back the bar. but it's
Yeah,
too
I
far
will,
because it's going to
but
jump in.
I'm just,
Yeah.
no, it's not going
Yeah,
to
see
jump
that
in.
we're going to go through the same multiple, those 3 points.
The 3 steps, yeah.
Yeah, 3 steps. 1, 2, and jump. Good. Beautiful. Go. Okay, we are ready, holding the guide with the left. I can pull the wire a little back. Once you are ready, go.
150, 150, 140, 150, 140.
What happened?
I don't know, it's not moving.
Yeah, but it's getting stuck, right?
Yeah.
It's getting stuck 1.25 bar.
No, it's not getting stuck. There's no movement. Okay, now, see, there's no movement here. See that?
Yeah. No, that's stuck. So you can
Not
come back
stuck
in the
the
guide.
lesion.
No,
It's
no,
not
I'm saying,
stuck
okay.
in the lesion.
1 second.
We're
Come
not
back in the
reaching
guide. Oh,
there.
good.
Yeah,
You're
good.
enough room. Yeah. Start here. No. Yeah, here. Start here. 1 second. 1 second. Good. So basically, as soon as you go to the angle,
The burr should be burring.
See,
Yeah.
it's not coming back. It could be, this has happened in the past with some issues with the,
no, keep it straight. Okay. Go
no,
again.
nothing with that. I did
Go
maybe
again.
disconnected here.
No, cannot be disconnected.
It
Go.
is. See? Not coming back, you see?
Okay, 1 second. 1 second. 1 second. 1 second. 1 second. Just 1 second. Yeah. Guide.
Even then,
Fantastic.
even then,
It's
even
changing
then.
the
One second.
angulation
Yeah.
of the guide.
Coaxial. Yeah.
Even then it's
Yeah.
not.
I'll
gonna
hold
come.
it and you go.
That's okay. Let me hold it. I'll hold it.
Okay. Yeah. 150, good. That's okay, wait.
It's already gone through the
Wait.
left main.
No, it's
yeah.
gone through the left
Yeah,
main.
but not to the lesion.
It's ostium of the lesion, of the circ now.
Yeah, you're right. Left main had done ostial circ, yeah.
Just the angulation direction change was the key there.
Yeah.
It's going to jump through any moment. Bingo. There you go.
Pull back, wait.
No,
yeah.
it didn't do.
So, and you know that soon will be coming with the burr coated on both sides. I have gone to looked into it. There is still a trouble with the 1.25 bar. So, but soon it will come. Yeah.
There you go.
Yeah.
Fantastic. Fantastic job. Just Sameen and Anu, we have a chorus of a very appreciative audience. Just outstanding teaching, great skills.
Now you can do the IVUS to tell us the nodule versus what. Guys, get ready both fielder and run through.
Anu, superb skills there. Excellent case.
Yeah, so basically was that even orthogonal displacement of friction didn't allow to have a two band coming out of the guide and then clear cut short band into the circ. So just as soon as we made alignment, it was able to do it. Still was very, very difficult. You always worry about some, perforation, dissections and all those. Give us guys wires.
Look, just to at that time to have had the presence and the expertise. I mean, this is as hard a rotablator case as you can, and I would have never thought that the way you found the solution was to back out the guiding catheter and make it more coaxial.
Okay, good.
Any challenges ahead?
Run through for circ. Run through for circ.
No, this is for the LED now.
No. With
Okay,
that,
then give a fielder.
yeah, fielder here. Fielder for the LED.
Yeah.
You got a new one?
No, fielder, I'm going to the circ. Circ is a side branch.
No, I know, but believe me, this will require a lot of support for your there.
Okay, give me a new fielder.
New fielder, okay. Go one, whatever you want to put meanwhile. Yeah, done. Throw it.
Believe me, once we do another thing, the circ will be okay.
Yeah, usually what
I don't need that.
Anu is saying that want to put a fielder into, what do you need?
I want fielder in the circ.
Okay, right here.
Okay.
Fielder in the circ. So question will be that why fielder versus run through into the circumflex? I felt that you still will need a lot of support. See this last picture? So calcified. Look at that. You still need a little extra support so that run through, knowing the run through went first time. Haha. The circumflex likes the run through, in my opinion. Now you can take the rotawire out. Good. Yeah, in this case, we'll take the rotawire out because we are going to put a 2 wires. We rarely put 3 wires.
To do IVUS.
No, but wire in the LED first.
Yeah, nobody makes the proper curve.
Yeah.
It's a needle.
What do you need now?
The proper, it's no curve here.
Were we able to get the picture from the Ninja?
Yes.
Show that. We actually showed about 5, 7, 8 years ago.
No. We
Swift
showed
Ninja.
This Ninja.
Swift
like
Ninja. No,
in
Swift
one of
Ninja
the
we showed long time ago. No, I know.
CCC also.
Yeah. Yep.
Not 7, 8 years ago.
So it's made, I thought it may be a non-US company. It's made by Merit and not available in the US?
Yeah, yet. Lot of new things are coming. Actually, FDA is a little lenient. They got the ringer balloon. Now our perfusion balloon is back.
Have you used it in a few cases?
No. They have given us two wires still lying. We have not used it, but I had to for appropriate case. We'll use it, but not yet.
So what do you consider an appropriate case for it?
I would say that there is some perforation,
Right.
and then I would want to leave it for 10 minutes,
Right.
and not
Probably
worry about
even
the
longer.
ischemia. Yeah,
Probably even-
exactly. Yep.
So finally we got this
No.
great technology after having it 40 years ago.
Yeah, that is correct. Shat's balloon.
So Anu, this is you are the right person to ask this question. Provide the tips and tricks of rota in angulated lesions to avoid wire bias.
So there was wire bias here. Okay, 1 second. Okay, we'll answer later. Let's see what the IVUS shows.
Okay.
Okay, can I start from here?
Don't think there will be
Okay,
a
start with
calcified nodule.
Yeah, it's a mid-circ. Come to the proximal. Yeah, 360 calcium. Yeah,
Yep.
I see a lot of ablated calcium left main.
But it looks like a more of a calcium rock, right? 360. That's what appears.
No nodule. Yeah.
No nodule. Yeah. Unless.
So
Okay,
this is
so
a
now
distal left
Good.
main and osteo.
let me do the IVUS of the left main to LED.
Sure, definitely 360 calcium in the osteo-circ.
And
360 still, so we will need IVL, right?
Yeah, still 360. And
Okay,
the-
let's
just the
get a-
surface is shaped with some reverbation.
3
but
or
still-
3.5 IVL.
I think 3.5 because we have to do the left main also. I mean, circ, if you're just doing circ, could have been 3.0, but we have to do the left main.
I think 3 probably will be safest.
Okay, no, let us
Okay.
see. Remember,
Alright.
if you don't do the right size.
Okay. Get ready 3.5 IVL.
Okay, Kiski, what are you telling me based on your imaging? I'm telling you based on
Kiski,
EYE.
how much is the size of the ostium of the circumflex?
So osteo-circ, definitely 360 calcium. We cannot see the EEF
2.78.
go to
But-
the body a little
Yeah,
bit down. Yeah,
definitely.
there.
So this is the proximal part of the circ. The
That's the
vessel,
aneurysm.
vessel size, at least follow vessel.
Okay, go
The-
distal. A little bit more down. Yeah, there.
Yeah, start of the pubic also some calcium. So that's like some part we don't see the EEL, but proximal circ, the follow vessel. The tightest part is like,
So you can use 3.5 or both.
yeah, that's good enough for shock on the
Get ready
osteo-circ.
3.5. Yeah.
Okay, now LED.
Sure, check the
LED is not,
image.
IVUS is not going.
Okay, start pubic,
Okay, there.
coming.
No, it's just
Significant osteal disease in the LAD also, I think.
So it didn't cross the LED, right?
I know it's not going, so let's not push it.
So let's do the IVL of the LED first.
Okay, I don't know if IVL go then, if IVUS didn't go. I flush it, get the IVL.
You want to do a balloon
Get a
first?
regular balloon first. You do want to
Yes,
try?
same.
Let me try. IVL does not go. Let's go with, you have the 3.0 balloon, right?
Yeah. You want to go to circ versus what? That's the question.
Now let's do LED. IVL.
Okay. 3 or 15 balloon for the LED. They'll fix it. They'll give it to them. Guys.
Go,
But
quick.
So, Dr.
Then
Sharma,
we'll-
maybe
No.
distal left main has a calcified nodule and the surface is shaped in the distal left main.
I see.
You shaved?
Yeah, surface is shaped. Distal left main calcified nodule.
Okay. So nodule somewhere.
Just from the IVL point of view, there is a new catheter which is laser based. Go to the LED.
I want IVL. I do not want.
No, you want a balloon first.
No.
Oh.
Only if IVL does not
Okay.
go.
So
Are we ready
The
with
called
IVL?
fracture, Bolt Medical, acquired by Boston Scientific, because every company has to have IVL catheter. Then there is another IVL catheter by Boston Scientific, Medtronic working on it. So we finished the trial of the Bolt Medical,
So
one
the-
of the highest. Yeah.
Question I have is IVL Shockwave, was it a $16 billion acquisition now
No.
that you've got competition from 6 places?
That's right. And that 16 billion will
Same.
be worth less than 1 billion.
Same thing you can say for
Okay.
Impella.
Abumed Impella too.
Yeah,
Give
exactly.
the.
Exactly.
Okay, good.
Yep.
Okay. Okay, 2 atmospheres. No. This is the old one. C2. Yeah. 6.
Yep. Went in. Very
I
good.
don't know why there's no die. Guys, this is not. Did you go? Okay. Right,
4. Yeah.
okay, down.
6 and down.
Let me pull back.
Yeah.
Okay, go here.
Yeah. Go here. Yeah. 4. Good.
I have to go to the mid LED.
Yeah. Actually, the issue with the Impella would be that they probably will stay in the market because they're
Go up
ECP
again.
catheter. As long as we has to be not yet.
Yeah,
We have to
no. I mean,
freeze.
without doubt.
Yeah,
I mean, they
yeah.
have got such a incredible pipeline and IP. But you start wondering. It's not like how it was
Will not
being
be.
a sole.
Ruptured. Right?
Okay, good. Guys, you have to wait. This is 6 and you come down.
I know whether this will go to the mid region. Very complex. No, don't push it. Don't push it.
Huh?
Yeah.
What's the point then?
No, but this one will not.
Yeah. Tight.
Yeah.
Needs
Don't
more
tell me we
f-
need rota there.
Yeah.
Huh?
Just 1 second. 1 second. Yeah. So newer catheter Bolt actually we found a little more flexible compared to this, but we found definitely a little more rupture with the Bolt.
Okay, go. Right?
Because remember,
And-
always will happen. Anytime your balloon will become softer, you trade off flexibility, crossability with the. No.
I'd like to acknowledge and welcome
1 second.
a physician from Syracuse, New York, who's been making remarkable comments throughout the case today. I have not had a chance to read all of them as you were concentrating. Dr.
out.
Suhaib Kadura, and he's from Libya. Suhaib, thank you for your excellent comments. He mentioned
sec,
that
right?
Yeah.
he keeps watching the archived cases because at the time of the live transmission, he often has his own cases.
Okay, go. Take this out.
Welcome.
So there's
Welcome,
another
Sohab.
question posted for you. Why do we have to inflate to 6 atmosphere from 4 before deflating IVL?
No, but basically what happened is you created the fracture, and now you want to flatten those fractures with a 6 for a few seconds. As you're pushing means basically those micro fractures, you want to make them little macro fractures. So 2 atmosphere only. And this is actually other IVL have the same mechanism. Some of them actually going even lower, 2, then go to 4, 3, then go to 5. The Bolt actually was many of the cases we did only 2 atmosphere. So purpose there is to continue after your cycles have been done, because that time only cycle cause the microfracture. So in subsequent inflation, basically just pushing the micro.
Oh,
You went? No. Why?
I thought I went on. Wait,
Where are you?
back on the
No.
other
Yeah.
one.
So basically, those microfractures kind of become further in the dilatation. To don't go very high pressure. Maximum is the 8 atmosphere. But 8, and that is what the whole purpose is. That why we have the lowest perforation with the IVL is because of the very low pressure. Although in the vessel, it is looking like a 40 atmosphere. Because of the energy, whether it's a shock wave energy or laser energy and so, but it has shown that it is the inflation of the balloon pressure which correlates. Now there is only one trial called Bali, B-A-L-I. Bali trial comparing against the non-compliant balloon had a higher perforation rate with the IVL, but every other trial of the IVL has been 0. This was the 4% in the Bali trial, but basically it showed the benefit of IVL, that better lumen and lower. Let's dilate first here.
Just the mechanism of how it acts
go.
is.
Okay, you can.
Oh,
Okay, good, going up.
I don't know.
4, yeah.
Look like we need the cutter. Go, press it. No, hold on. You have to go. Not working?
Yeah. No, going. Keep it.
Get
It's
a
3.5
cutter
cutting.
then, right?
3.5 cutting.
Now what are you going to do to the mid LED? Okay, down. You can feel that. Get us the 3O.
Good.
Balloon. We have, right? Or you want 3.5?
No, 3 is okay right now.
Samin, I want you to reflect for a moment. Often we have this feeling, probably these are some of the benefits going from CCC life. And then suddenly somebody explains it so beautifully, which is highly satisfying. And I'm going to read it as it is.
Yeah.
So this is Dr. Ashwin A.B.
Yep.
So he was the one who asked the question, why do we need to inflate to 6 atmospheres, then to 4? And then he writes here, well explained. Thank you, sir. Had this doubt unanswered since a very long time.
Yep. And Ashwin is a very good friend. Ashwin Mehta is a AB Mehta from, he's,
Ashwin,
he's
hi.
still, and he's still,
Of course.
Could be somebody. There's no way.
no,
AB Mehta
Ashwin is
joining.
from India or no?
No, please.
We can ask.
Ask,
Ashwin AB, is this our good friend Ashwin Mehta from Just Look? Okay, so that's a 3O balloon?
Down.
Yeah.
There you go.
18.
It's a 4O vessel. Down. I think we still have to do the IVL, no?
Down the circumflex.
Go a little
Yeah.
further. Okay, let me go up here.
If you wanted, then I would have gone first. Ay.
Ready? That's okay. Let's do it here
go.
and then we'll go.
Okay.
I think this will crack it.
Yeah.
Okay, down.
18. Okay, now what we are going to do, if it does not go, there is a trick. You decrease the profile by inflating keep it in size. See this now. In the guide, now I'm going to go 20 atmosphere. So now what it does, the guide is going to wrap the balloon, and then we call technique of decreasing profile, and now go. So this is done very commonly in India because of the used balloons. And they do work, but not every time.
Maybe works in India.
No, but no, remember, this is very simple. I knew
But,
because fielder wire is a very weak wire, is going to give trouble. I predicted this difficulty. Now, what do you want to
That's
do?
not the
Cutting
reason.
balloon or
It's
what?
still a lot of calcium there. That's the
Agreed.
issue. Yeah.
That is
But
why you needed a stiffer wire.
no, if we had gone with the balloon directly, distally and dilated, it would have happened. Okay.
Okay, what do we need now? This was the used balloon. We can use a
What
new
is
balloon.
that? Cutter?
Anu, you were right. This is not Ashwin Mehta,
I
another
told you. Please.
person.
Okay.
But very nice meeting you, Ashwin, and thank you for your outstanding comments. And keep communicating. And this is the other part, we've always had this feeling till somebody writes it so clearly that, we watch the archive cases all the time. Sometimes the scheduling doesn't enable everybody to join in live.
And they can still ask the question in the archives, and Kim usually brings those questions to us, and we do answer later on also.
Excellent.
Yeah, very important, yes.
Forget the left main now.
The wire crisscross now.
I don't think crisscross. IVL went. Just these balloons. Okay.
Okay, I'll tell you what you need to do. 1 second. Let's see, there's no dissection. Take a picture. Then bring the run-through wire into the circumflex. Yeah, good. Bring the run-through wire in the circ right now.
No.
While you are there. No, it will go. I'm saying it
It
again.
was not, believe me, it was not easy
give it
wiring a
more-
LED. I would not.
You
Give
want
me
to
another
give
wire.
it more body, huh?
Yeah.
Get me another wire.
Run through,
Look,
run through.
I know the struggle continues, but the lesions are looking excellent. We've made great
Yes.
progress already.
That is
No, we
correct.
could
On the
probably
right
go
track,
with another 3-5 balloon and just dilate it there. Or you wanted
Stepwise,
to go to the. There's so
Good.
much.
Let's cross.
I mean, in a single case, you've had plan A to plan Z. This doesn't work. Let's move to the next, to the next, to the next, and it is making slow
Bye-bye,
and
bye-bye.
steady
No.
progress.
This is bye-bye. Guys, hold it. Should have paid attention to. Hold it.
What was that?
Floor.
No, don't.
just touch the
Understand,
floor.
Don't hit outside. This way.
Okay. Okay. No,
Oh,
if we
okay.
need it.
Okay,
Yeah.
fine.
And question is which size, 3 or 3.5?
Oh, you wanted in the circle.
Good. So let's get that our cutting balloon.
I would not go with the cutting
Yeah,
balloon.
go. No,
regular.
want to demonstrate to the fellows.
Oh, no,
that will
just,
go.
and no torquer there?
Yeah.
No, nothing.
Good. Let's go on
Unbelievable.
this. No,
I
on
hope
the
you have seen the
run
ceiling
through.
camera. You can go and see.
Yeah,
Dr.
yeah,
Sharma
yeah.
was giving me torquer. I just kept,
No,
avoiding
just
it.
amazing skills and
No torquer. No. We needed torquer was for
Yeah,
that
Go.
tough time.
Yeah.
No, I would have gone with the
Yeah, I know,
fielder
I know.
itself.
Go.
so Samin, another useful comment here again from Dr. Kadura. I know we aren't there yet, but I anticipate they'll use two-stent strategy with that
This is a mini crush.
angulation.
Yeah, mini crush. No
into
question
the
about it. Mini
circ.
crush. Yeah.
Now the question is, do you favor a certain stent brand for radial strength like the Megatron?
Yeah, but Megatron with the mini crush is very difficult. Very difficult. So, but I would say that one could be Megatron if need to be. Another one just regular. So much wire crisscrossing, huh?
How can there be crisscross? Oh, okay, there.
Okay, let's take it out. Want to go on fielder? But that's less. Good. That's okay. There's a branch also. Big branch.
I know, but there's a significant disease there. Close with the wire.
Good. Okay. Good.
So the buddy wire worked.
Yeah. Good. And the run through. Yeah, the buddy wire is the run through.
You can never say fielder would have gone further down.
Yeah. 12, 14.
Hey, something happened.
Patient patient
No,
hands
no,
on
no,
the
no,
chest.
no, no, no. It's a single shot. Changed.
Yeah. Patient hand on the chest wall. Ask the patient, let me go further.
It's not happening.
It will go.
We may... Okay, down.
Yeah, once it is there, it will inch through.
As
Once
I
your nose is in the
listen,
lesion,
we need to move fast.
then cutting
He's
balloon will go.
getting
Yeah,
restless
further.
now.
Yeah.
First time he started moving.
Go again. Go again. Now pull back and go again. Good. See, always come with a speed. Speedy Gonzalez. Good. That's all. We don't need more than that.
Yeah, down.
This is a 3.5.
Yeah, yeah, yeah.
Yeah, because vessel is 4.0, 3.5. So we could not do IVL. Yeah, Yeah, good. So technique, just let me say the technique again of the cutting balloon is that you had to do at least 3 times, come back and go in and do a multiple inflation. Second time you do a little slow inflation, but come back and go in. So those are the identified cutting balloon techniques. Ready?
Okay. And I would not do anything. He's moving.
Yeah.
That means
Let's just put a
finish the
stent.
case.
No, but
No, we have
LED.
to mid LED.
No, mid LED later. Let's do the.
No, 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 no. Finish the mid LED right now.
Okay,
Because
then go to
we'll do
epicranial.
one
You want
stent
to take a
from.
picture?
Okay,
Let's
you
take a
can do
picture
that.
and then we go epicranial. Yeah. Beautiful. Good. Take the, I would say, yeah, fielder wire out. You don't need the fielder. Yeah,
Okay,
let's go
get
to
us,
epicranial.
There
No,
could
keep it
be a
there. So
lot,
go to the
lot
diagonal
of,
if you want to do
lot
it.
of
No, I'm not going
ischemia
to the
from the
diagonal.
mid
Please.
LED.
Yeah,
Yeah.
yeah.
Yeah, yeah, yeah,
Go to
yeah.
epicranial. 1 second, guys.
We can actually see the mid LED from here. What balloon? Get us a regular balloon,
3O,
right?
3O balloon we have.
You have 3O?
Yeah.
No, that was used.
Yeah,
May
we'll
not
go. No, no, we'll go. The question is, do you want to protect the diagonal with the
No.
fielder wire you have?
No. Just focus on one thing. Let's finish the case.
Okay.
I think as soon as you dilate that with the balloon, the vessel will be.
Okay. Want to take picture or you want to just wait 1 second?
It's not going
Okay,
to
let's go up here. 1 second.
No.
No, there is a disease there. We did not do rota, very calcified. Let's open it up with a balloon. This is 3O balloon, right? Yeah, good. That's fine. We'll
Get
go.
us unused balloon again. Maybe a 2.5 down.
High pressure 20. Yeah, yeah, good.
Tell them close it.
Go further.
I would not go high pressure. Give me a regular balloon first.
Okay. Yeah, just 1 second. Try again. 1 second. Go again. Just 1 second again.
Getting EKG changes.
Mm-hmm. Okay, take it out. 2.5, 20. Non-compliant, right? Non-compliant.
Compliant.
Okay, compliant. Okay, this is the lesion we are tackling now. Oh, took it out. Okay.
Maybe needed double vessel rota then, right?
Yeah. Go.
Now his EKG change. You can, okay, yes, he's having a few, some EKG changes.
No, it's okay now. EKG, there was some EKG changes and now a little better. Yeah, any balloon into the LED. LED is more important, looks like, than even circumflex. More EKG changes when balloon is in the LED.
Why did you take a 20?
Huh? This is a compliant balloon?
Yeah, but why
2.5,
20?
No,
20
that's
will
okay.
never make
20.
a turn, Gute.
No, but let's take a picture what the story is.
Okay, no, nothing, it's just tight.
No, we can put 1 second, then we can put a fielder wire again into the LED and then we'll do the balloon.
Get me a 2 or 12.
Yeah.
Yeah.
Yeah. No, but what I'm saying is here, You have everything there right now. Take this wire out, try to see if it goes to the LED. 2.2012 compliant or non-compliant?
2012 compliant.
Yeah, you want the lowest profile.
Yeah.
So, I mean,
Very
there's
calcified.
a quick question. Were you concerned? You had two wires there before using the cutting balloon.
Yeah, so question is that as long as the vessel size is okay, because what happened is the less than 3, your 3 blades, and 3.5 and above are 4 blades. So as long as you are careful,
Get the
that
balloon.
size wise, yeah, go with this. Okay, take this out then. Yeah, so key, the leaving 2 wire and the cutting balloon is completely okay. As long as you don't go high pressure and the cutting balloon is little undersized, although it's the 4O vessel, we are 3.5 cutting balloon. And if required here, I think we can quickly go with the rota.
So at the moment, we are not planning to touch the diagonal, but somebody did observe that you have a double bifurcation case.
Yeah, that is correct. So, remember, more you keep the patient on the table, the more restless they become.
Absolutely.
And there's more trouble. So let's see the last picture. He's bringing hand here and there. Yeah, it's a good sized diagonal. And there's very tight lesion at the ostium.
That
Give a little more
observation is
sedation,
a good one, yeah.
But the key is the circumflex lesion looks quite
Stable now.
okay, stable, yeah. I think we should do rota. 1.5 bar or 1.25 even.
Get the fine cross. I don't know if the fine cross will go.
Yeah, it will go. Good. Okay, get a 1.5 bar or 1.25.
Let's get the fine cross quickly.
Yeah. You can still leave the Vico 7 French guide. We are going to ablation a little further down. We can leave the wire into the circumflex. Not a problem. We are going with the fine cross in the LED and getting the rota wire. Get the rota wire ready. And the question is 1.25 or 1.5?
No, I mean, circ wiring is okay. I don't know.
Yeah. No, but you can leave that. That's not an issue. Get a 1.5 bar ready.
I think surgery would have been done by now. What we are struggling.
Okay. Put this one wet towel. Now this is a 1.75 bar, and now there is a
no. It's a 1.5 bar.
Sorry, 1.5. Yeah, 1.5, 1.5, and put a towel on the our IVUS catheter. So people are worried about single that you don't have the exchange length wire in the LED. Not a problem, as long as it's not a stiffer wire of the CTO. Your fine cross and so those things will go. While you are taking out, you put a indiflator in the end and go fast, and then it will come out. So with a single wire technique, it can come out. Yeah, I unmagnified. Go. Rota wire is there. Yeah. See, just keep everything straight and it will come out. Good. Went in. Now question is, will it cross? Even if it does not cross, this good.
Leave it.
Yeah, that's okay. Even if it does not cross, we are okay because nose is there.
The hands by the side.
Yeah. No, you need a new wire then. This wire has seen its days. Give a new rota floppy. The tip is bye-bye. Oh, 1 second. If went further, then fine. Here. Yeah, then fine. Yeah. Then we can do. Okay.
So you see the technique I used to get this thing further down.
Yeah. Yeah. This is a run through. We are going to need it. Go. We'll go in. Now, if let's say it would not have gone, then you have to get a good wire tip of the rotor. The wire tip is a little distorted, but that's okay. Because now your fine cross is further down and you'll just change it. Do you know what they're doing in room 3? Good.
So, I mean, almost
Hands by the side.
getting to 200 cases. It did not escape my attention watching the case today that, you know, the commitments that are needed to provide all these live cases. Just imagine, I mean, it doubles the time taken for a case to go slowly, explain methodically, and you know, it could never be easy with the logistics of such a busy lab. I heard you ask what's happening in room 3 and all that. You know, all those pressures. You both of you maintain such a amazing composure to continue doing this, and I have never in 17 years seen any shortcut. The case has required more time, more commitment. It's always there. So I'm sure the audience has appreciated. Probably these are some of the things which explains the loyal support we've had from people.
And you know, to have no other webcast has consistently 25,000 plus audience. You want to just go in? Yeah. Per month. I mean, this is tremendous. And every time the countries keep adding on, even maybe one case from Kenya or
Libya today. But
Libya.
look, the amazing part is that I think we've always underestimated the number of people who view and the halo effect of it. You know, people talk about the cases.
Yeah, absolutely.
I would remove the
Take the wire out.
yeah.
That will be okay. Good.
Okay.
You see that with the 7 French, we are able to put a wire. Still left the wire in the circ, and we went with the LED. We want to pull back a little bit.
This is the 125.
No, 1.5. Same which we use for
same
the circ.
burr. Yeah, same burr. Yeah.
Good.
I think it'll go.
Yeah. Yep. Go. Good. 1 second. Yeah. Go.
That's excellent job. Excellent thought to use it.
Yeah. You want to do one more?
No, come on.
Entire midsection has been
Ready?
successfully ablated.
Hey, there's a hey. Stop. Remember, there's a wire there.
That's okay.
No, you
Coming
can't
back.
do. You still may do something.
No,
Just
no,
take it
not
out.
coming back. There's nothing there. Sorry. 1 second.
Yeah, I pulled
1
it out.
second. Go here. The back end. Remember, it's the back end of the wire.
Doesn't matter. It may still scrape it. I just pulled it out. I actually would want to take this rotor wire out. Take it out.
Yeah.
Okay. Let me run through.
So the question asked again from Dr. Kadura is that, of course, you come back out always on Dynaglide, no?
Yeah.
Yes.
Yeah, actually, you know, originally when it was introduced in 1992,
Where was
it was advised to go with the
no?
go with the Dynaglide in, but then they found a lot of debris at the angle. You go forward with the Dynaglide. So
now
that,
you can give me that.
Then about 94, by the time we got into, so it was 1.5 years in the market, and actually, you know what? Who said that? Nicholas Reifert, who did the Arbeck trial. He said, you know, I'm seeing a lot of slow flow just by when we are pulling back, and so going forward before even burr gets in. He said likely it is taking the particles from the guide catheter. And so that in about 1.5 years, it was abandoned. If you go back to the Arbeck trial, you'll see it. It's written there that on the Dynaglide you go inside. So it was abandoned very early. Same thing like when we did our tower. First tower was transeptal, second tower was transeptal, third created the laceration.
Can I take a picture?
The whole the papillary muscle ruptured.
Okay,
and
are you 7.5?
I'm sorry, what?
It's not 15 or 7.5. Okay, okay.
Yeah, yeah.
Looking good there.
Very good. Yeah.
Okay, diag is gone.
Diag is gone. I was just going to say, diag is bye-bye. We'll come back.
I think.
But we are not given our vasodilators. Get the verapamil.
Let's say with the vasodilators, the diagonal is restored. Would you then go back and?
Yeah, definitely.
It?
Yeah, good. Go.
No changes on the EKG.
Yeah. 1 second. Here, let's go. Yeah.
It's
So let's say at is small, and then all of a sudden, 1 second. Let's see where it is. Yeah. Still, you have a little ghost. Yeah. So I would just say this. Try your whisper or fielder right now before you go with this balloon.
Get the fielder.
Fielder. Or we have the whisper actually. We had a whisper earlier.
No.
No? Okay. Okay.
First time I see a blood pressure drop.
No, this is the medications. Iatrogenic drop.
No, but even. Oh no, what is this you gave me? Give me fielder. And then get us a. We had the 2O balloon or something, right? Didn't we have?
Yeah.
Yeah, just let's open it, right? 2O. It's a big vessel.
Yeah, we never dilated that. It's an undilated balloon. Uninflamed. But EKG changes persist. I mean, blood pressure persists with some EKG changes now.
Yeah, exactly.
Fill up some more nitro. Keep it there.
So shall we die? Is that where we are?
Yeah, good. This is it. Let's get the balloon there.
Wait.
That's okay. You'll need a balloon support. Very tight lesion at the ostium. It may be going through dissection channel, whatever, but you bring the balloon, it'll give you some support so they can modify the direction.
Okay, I hope after this we will have dilate the diagonal, dilate the LAD's stent.
So as soon as we put there, then I can go to my some presentation because we have not done anything yet.
I think we can skip your presentation for today.
Yeah. And see that patient is very nicely, although very restless, but
very restless
our nurses are doing a terrific job. Ryan has done so far great.
Yeah, he's restless, I think, as soon as we started LAD.
Yeah.
Where is it the right diag? Because
probably a dissection plane there.
Yeah. This is.
It seems to be in the right place, right vessel.
Yeah.
7. Right, it should have gone. Can you
Balloon
give me
further.
some dye?
Yeah, but pull back the.
Yeah.
Yeah, it's in the right.
Now
Two diagonals there. You were in the right place. I can't remember a case like that. There were challenges and obstacles throughout.
Right,
Nothing has been achieved easily.
Yes, that's this case. Yeah. What do you need?
I don't know. I think I have to go back to the same view and see.
Yep. That's it.
Okay,
Beautiful.
that's it.
Excellent, excellent job.
So
Excellent,
that was
excellent.
just to, rewire into the right one. Maybe it was in a smaller branch.
Hmm?
1 second.
Okay, you know what? If wait, don't do anything. Let me just. Everything is okay. Once the patient is restless, very hard for the operator. Okay, take a picture before you do anything. Let's make sure we're in the right branch, not the upper branch.
Yeah.
Okay, good.
What came back?
No.
Now
What
we can
came
go
back?
to the lower branch. Yeah. Good. And then we do a 2.25 cutting balloon in the end.
I would not. Keep the balloon,
Good.
put the stent, and that's it. EKG is better. Okay. Okay, down.
Go a little more further.
No.
No, go a little further also. Yeah.
No.
Yeah.
I don't want to.
No, there was disease.
There can be disease. The plan is to keep the diagonal open, not dissect it.
Uh-huh.
Okay, take a picture.
The whole area is disease. You have to dilate a little bit more. Go from that angle. We just have to. We are in right direction. Yeah.
No, that's not the thing. We already dissected it.
Yeah. But that's okay. Yeah. Just here. Yeah. We can do a double mini crush. We are done one time.
Down. You're already 9:30.
It's a big diagonal. I'm saying it could be a case for double mini crush. I'm telling you. That's the best dependable results for this case. Can take 2.25, 28.
Okay,
and
down.
3.5, 48.
Okay, get us a 2.25, 28. Zions. Okay, down. But then.
And no, you can put actually two separate the mini crush, because remember there is a large vessel there, proximal LED. So you can put a 3.0, 18 and 2.25, 28, and then we do proximally covering the left main and the circ. Good. Keep this balloon, we'll need it. Yeah. You want to take a picture now? Doesn't matter, you have to put a stent. Yeah, good. 2.25, 28 first, and then 3.0, 23. 3.0, 23. Yeah.
Right moment for you to begin your presentation, I think.
What do you think? You want to wait? Leave this balloon here. We'll need.
For what?
No.
Remember,
no,
if you're going with the stent.
Yeah.
Or did we ever dilate the LED? We never dilated the LED.
In the mid portion, no?
Yeah.
That
We need that.
That was the whole purpose. Let's go back again. Yeah, that's okay. That's all right. We are taking a 3.0, 23. Yeah. You want me to, while doing, you want me to go for presentation or just wait a few more minutes?
Let's finish this one mini crush, then you can go.
Yeah, let's do the first mini crush and
Absolutely.
then check. Yeah.
Anu, this patient has been on bivalirudin or?
Yeah.
Yep.
For the live cases, we always have a vein. So Ryan is keep checking here the ACT. They know. Like we have the protocol, they also have their own protocols. Yeah.
Huh?
383.
Yeah. So actually, you know what? There was one medico-legal case advance that patient developed thrombosis and they never checked the ACT even with bivalirudin. And you cannot defend it, because at least I know, because they say guidelines are not there. I say, but still, what if the bivalirudin was never given?
Go.
Right.
Okay.
Yeah, go further. Yeah.
No, no,
IV,
don't
I
go for
went
that.
20.
IV infiltrated. There
Yeah.
can be so many
Yeah.
reasons.
Little more.
Samin here,
Yeah.
Go.
I knew this would come to grasp us at some stage.
20.
Question is, would you use a drug-eluting balloon?
Where? For which vessel? you mean?
I'm
the
just
diagonal?
reading. Yeah,
There's a
I'm just-
dissection, my
Yeah, I
friend.
know,
There's
yeah.
a bad dissection.
We have gone through this question
Yeah.
last time also.
Yeah.
No, which
The-
is why I
yeah.
said that it is going to hound us again.
Yeah. So key is very simple. Drug-coated balloon, drug-eluting or whatever DCB, DEB is only substitute for the stent-like results before DCB. Means that the lumen is nicely open, less than 30% without significant dissection. Maybe A, type A, maybe a little bit of B, okay. But this is a bad dissection of the diagonal.
Yeah. That was the only reason we changed. Remember, my goal was we just balloon stent across and move on. But now there's a dissection, we need to stent it.
Good. Okay. Let's go to the diagonal first.
The only question, I think, LED not fully
Dilated.
Yeah.
No, it is dilated now.
Okay. No, get a side branch?
Yeah.
Okay.
So clearly side branch first.
Hmm. 3 already?
Yep.
Just noticed something else, Anu. I had noticed that about Samin too. It's, I don't know what vision health you both. No glasses, nothing at all.
Not yet.
Yes. Enjoy it till you can.
Yeah. Actually, yeah.
It's
That is true.
It's a
Lot of our-
God-given.
lot of
yeah.
our friends, little envious that you don't need it. I said, well, listen,
Nazar,
I
Nazar.
could not read much before, and now we don't want to see too much. Okay. Now we are going with a 3023 in the LED, and 2.528 is already there in the diagonal. The first mini crush.
When we were looking at the film that was from the other hospital on this patient, Kiski and I had looked at it and said double mini crush. Kiski first looked at it, said double mini crush today.
Yeah.
I said, let's try to avoid it, but looks like we have to do it.
Yeah, once you have such a disease diagonal, this is a classical case that can you come with a single stent approach? Answer to that is no, because of the length of the lesion and tightness, both.
So, I mean, this is a very unusual request, but a few people have requested they want to see the left main stenting live too.
Okay, some die.
Yeah, good.
We can easily accommodate that.
Yeah.
Which
Good.
one? Hold on. Let me get this.
Just bring
back
the LED a little
little
bit, 1 millimeter back. That's it.
Okay, good.
Good. Ready?
Okay, you want to see a little bit again? Too much crush is not good.
Yeah, probably too far back.
No. Just 1 millimeter further. I think we'll be okay.
Okay.
Ready?
Yeah, go up.
Okay. So diagonal stent being deployed.
Can we do the mini crush technique
14.
app? Non-left main, then go to left main. Okay, good. Okay, let me take out the wire. We may need a new fielder wire. This is all right.
Get a new fielder wire.
Okay, some die to make sure we are good in the
Will
LED.
die.
Just
I
a
don't
little
need a
die.
cine. Yeah, good.
Okay.
Ready?
Okay, go up. Go up, go up.
$16.
Okay, down. Okay, go up again.
And to go a little distally also.
No, not do any of that. So we will need a 3, 5, maybe 18 for the left main. Okay, no.
Not 4-0.
We could go forward. Kiski, did we ever have a chance to look at the left main?
Left main, yeah, left main, 4, 5
4-0?
vessel. 4, 5, but
4.5.
lumen is 4 enough.
Yeah,
Diffuse
4 will
plug.
be okay.
Yeah.
Yeah, 4 is fine.
Okay.
4 or 18. 18 or 23. Bring both of them. We'll let you know which one.
Okay, hold on.
Take that filter wire out anyway because we don't need that.
No, it may go. I'm just trying to see.
Okay.
Oh, if your new fielder is ready.
I can also
Yeah.
prepare our audience for a
Hmm?
presentation by Dr. Samin Sharma at 200 miles an hour.
Good. Ready? All the wires have been out. You can take a little picture.
Yeah.
Put a black wire a little further.
Hmm.
Good.
Another question has come, which is your preferred wire
wire?
for rewiring?
You can take
It's
this
a
out.
fielder.
Yeah.
No, no. Let's. Do you want
Yeah.
to
Fielder,
try?
fielder.
Okay.
Yeah. Yeah. Bad.
Always a hydrophilic wire. And same recrossing is the optimal cell. Okay, let's not start the process of proximal and distal cell.
So we have 2O balloon ready. Once we go into the diagonal, we do a 2O balloon first, and then we go to the 2.5. And so we have them.
3O you had, right? The only problem is used balloons, not that easy anymore, right?
Get a 2O balloon ready.
Not easy to cross here.
Well, nothing in the case has been easy. You didn't expect that trend to be broken here.
Yeah. No.
For the 20th time in this case, Anu, great job. Still not there yet.
Mm.
Okay, here we go.
Not in the main vessel. Can you give some dye when I'm struggling there so we know? Okay. Where is the 3O balloon? You have?
Don't try first.
No, it's not going to go. There's so much of calcium
Okay.
that I think we need to anchor. Get me a 3O balloon. Yeah.
Yeah.
Question is, would it go?
Let's go.
And 2O, right?
Yeah. 2O is ready. So first we are doing the 3O into the LED, go high pressure, open the cells,
that's not the thing.
and then maybe
No,
anchor.
no. If you need to open the cell, we have to do it before we cross.
Yeah.
Recross, I mean. I'm keeping this ready to anchor. Okay.
Good. Go to first.
2O balloon.
Yeah.
Because we don't want to try it and then try to do, we predict it's not going to cross and then be ready with the anchor. Show the anchor technique, Andrew. Okay. Andrew can actually probably, right?
Yeah.
Say moderate bifurcation case.
Yeah, of course.
Proctor also. He'll be a good proctor. Oh, okay.
Good.
Samir, something went without struggle.
Yeah.
Go.
Look,
Okay,
The
down.
atmosphere. Pull back the other one. We'll go there. Good.
Good. Now go up high pressure for the LED first, then
go.
we do the kissing.
how high
18,
are
20.
you going there?
18.
Okay.
Okay, down. Now while we are kissing, it's 8 to 10. Okay, good.
Diagonal back.
Yeah, I'll bring the diag back. Okay, good. Now you do the kiss.
More.
Yeah,
A little
yeah,
more back.
yeah.
No, wait a second. Diagonal a little bit more back. Yeah. too much. Good. Now bring the LED back. Let me
Okay.
go first, otherwise it's going to watermelon seed.
Go,
You
LED.
go. You go.
Now we are a little bit
8 to
outside,
10,
which
no?
is
Yeah.
okay, since we are going to stent. Yes. Okay. Down. The one thing I can do is take this run through wire out and use a fielder to go into the circ, no? What do you think?
Okay, let's
Okay.
take them out first. We are done with these.
Mhm.
Take those two things out.
I think we can, what do you think? I don't pre-dilate the circ again. I think we did a good,
No, circle has been open now.
no, but now since then we have not gone back and we have,
Okay, we have a 3O balloon. If we need to be, we can do it once again. But let's take care of this first.
okay.
So we are done. No, wire of the diagonal further. Always your black portion of the wire should be distal to the stent or balloon. I mean,
Go, go, go.
where you are done. Otherwise, you'll never be able to see the dissections. Good. Let's go to caudal view. Beautiful.
Five-setter tennis.
Good.
Ready?
Yeah. Good. Let's get the stents ready. You want to take a picture once again, or we are okay?
Well, let's take a picture.
Okay,
Just
3.5 18 for the
and
circ.
4-0.
And 4.023.
Okay.
Or what 18? Probably both could be 18. Right? Or circ longer.
Yeah, get a 23.
3.5 23.
Yeah, yeah, 23.
And 4.0 18.
We have to come all the way till here.
3.5 23 first. But look at
Okay,
the.
let's go to the left main mini crush and get us a 408, or you want a 4.5? I think 4.0 is good enough. No?
Yeah, 4. Yeah. Give us, what do you have? 3.5 Yeah, first. No, left main was very big, so we can go 4.5 low pressure. So as soon as we do the left main crush, then we go for talk, and then they'll finish with IVUS, and then we'll come back to conclude the case. Okay. Now first we are going into the circumflex. This is the 3.5 23 for the circ.
I'm surprised you chose a 4.5 for the left main. I thought.
I said 4.08.
Yeah,
but
4.08.
for the post dilatation.
Post dilatation,
Right.
8 millimeter pot balloon.
Yeah, pot
Right.
balloon.
Proximal, yeah. But I was okay with 4. No, you need a longer SS, no?
So something else went easily.
Yeah.
Someday, see that?
Yeah, okay.
Perfect.
That's fine.
Come back a little bit, yeah.
Yeah, good.
Then give me a 4.0.
18.
18?
Yeah. And question was for the pot balloon. That was the issue, whether you use a 4 or 4.5.
Correct.
No, but if Keski is saying the left main is 4.8, right?
4.6 better. Yeah, EL
4.6.
to EL. Yeah.
EL to EL.
That's
yes,
4.40. Then get a 4.0. 4.08. Now
EYE is telling 4.0. Let's go with EYE.
Yeah, 4.0. And actually there is a new pot balloon available in America also now, which has no shoulders. It's like horizontal. So it was introduced from America, India, and now they actually have it in French. Sorry. Yeah. The French group also have, that basically is, let's take a picture.
Flat balloon.
Wait.
Yeah, basically
Wait
flat.
1 second.
Yeah.
This is a circle.
They actually call it a pot balloon, and there is no shoulder in that. That's the key. Pull back the LED also. Good. Looks
Okay,
good.
now 1 second.
Yeah.
Yeah, wait.
Ready?
What do you think?
Okay.
Good, no?
Very good. Very good.
Yeah.
Okay, go up.
1 second. And pull a circ wire a little bit. Fluoro.
Okay.
Always be the tip of the wires. Yeah.
Circ.
Circ.
Oh,
16.
okay, down. Too much crush. Okay, down. Okay, 408 ready? Some die.
Good.
Wait,
Looks
let's say a little.
excellent.
Yeah.
Okay, yeah, come here. Some die. I want to make sure the left main is fully covered.
You can
Looks
pull
good.
back 1 or 2 millimeter more. Yeah, good.
No, hold on. No.
We are good.
Okay.
Yeah.
Yeah, go.
Yeah.
408 ready?
16.
Okay, down.
Samin, it's also been quite amazing how well the patient has tolerated it all.
Yeah. Yeah.
No, see, when we were doing LED diagonal, he got a little restless with EKG changes and all that, but Ryan handled it.
No,
Yeah,
yeah.
yeah.
A
He's
little
saying
more.
yours.
Look,
Overlay. Yeah, good. 1 second.
I don't remember the EF of this patient, but
Normal.
many a people would have put an impella there.
Yeah, actually, the
discussion did
original
happen.
plan was to do the impella, but we said based on our guideline, it does not need impella.
Because of the EF.
EF, yeah. But this is a kind of case you could have a bailout.
Pump.
Now let's
Right.
take a picture so that while you are doing the kissing and
Okay.
I can talk my things. Here. All right, guys, let's look into it. Haha.
Unbelievable.
Ostial, you have to open a little more,
Yeah.
but they'll do the job. And let's go to the presentation now.
A chorus of celebratory audience here. Wonderful.
Beautiful.
Just outstanding.
5-setter tennis match.
Yeah.
All right. So
Wimbledon
Still
Centre
going on.
Court.
Still going
although
on.
right now Australian, no, what is Australian right now?
Open
Right?
is
Yeah, coming up soon.
Good.
No, already started. First round has been.
Okay, let's go to our, we'll go a little fast. Recent publications of the trials, Tuxedo 2 in diabetic patient, easy predict, PCI outcomes in surgically ineligible patients in VA hospital, then outcome of advanced plaque modification devices in CTO PCI in a calcific lesions in ER CTO registry. And focus review is contemporary
Do the
outcomes
PCI.
of CTO PCI with a CTO PCI where we are in present and future. So quick Tuxedo trial basically was the supraflex cruise made in India, SMT, which is a biodegradable polymer, sirolimus eluting stent, compare against Zions, which is a durable polymer and eluting stent. Rest of the characteristics are shown. It's much thinner. So Tuxedo 2, actually, they presented many sub-arm of that. One of them was the supraflex versus Zions family. Then there was 2x2 factorial design of using Pressagul versus ticagrelor. And then they say we are going to combine all the supraflex, Zions and compare them. I mean, that's the stent group. Compare them from the cabbage arm of the freedom trial. So that part is the only one not shown yet. Two things have been shown: original Tuxedo 2 trial and the Pressagul versus ticagrelor. So basically, this was enrollment of 1,800 patients. As you can see, basically matched. Everything else, success rate was identical. And they had a very good in terms of risk factor modification, and target lesion failure came with the non-inferiority. It was 7.92 in the supracruise, and in the Zions, it was 8.75. So, and then individual endpoints are here. TLF, ischemia Dillon, TLR. Look at the TLR, 1%. Unbelievable. Cardiac death and target SLMI about 6% and so. So other secondary endpoints are shown here. No difference in stent thrombosis. Somehow the SES supracruise has kind of trend towards higher stroke rate. I think it's just a fluke which happened. Remember original trials also, landmark, they did have a slightly higher mortality, but no difference with the supracruise stent against the Zions. But overall looks like identical, no individual subgroup analysis. And second point was, what if in this diabetic patient ticagrelor versus prasugrel. And of course, you can see here, about half and half got prasugrel or ticagrelor. Some got the clopidogrel, 90+% got the aspirin. And basically what we said, the non-inferiority was not met. Why? 16.57% event in the ticagrelor group and a 14.23 in the prasugrel group. Because remember, the inferiority margin was 5%, and here the basically was 6.7 confidence interval. So clearly it did not match. You know, they use all this fancy term that inferiority was not met. It was not inferior to inferior. Forget it. Simple, ticagrelor was inferior to prasugrel. Simple way. And that basically is, you see event rate was 16.57 versus 14.23. Individual endpoints are all here. Red is ticagrelor, even MI, even stent thrombosis. All you see, the kind of trended towards, although not individual, but trended towards higher event rate in the ticagrelor group compared to prasugrel group. And within this study, there are actually two groups. Patients who had diabetes less than 5 years, prasugrel was superior, statistically superior, and so also in patients with a high bleeding risk. So two subgroup of these patients where ticagrelor was inferior to prasugrel. So now you combine that with ISAR React 5. Remember ISAR React 5 in the patients with acute coronary syndrome evaluated ticagrelor versus prasugrel, and it was ticagrelor was inferior or prasugrel was superior. And if you take both of them, you can see 22% reduction with the prasugrel in compared to ticagrelor, and the bleeding point of view, almost no difference as can be shown here. So although, you know, slightly higher bleeding, you could say minimal. So second was EG predict. We always talk about you have done a complex lesion PCI. Should you do FFR in the end? And if you try to optimize the FFR, what are the results comes out to be? So see many times post PCI FFR on the left side, many of them has less than 0.8 after successful PCI. You dilate, or put another stent, final FFR goes up. Same thing for the DPR, and 17% of cases, and overall showed that no matter what you do, about 7% of the cases were still ischemic on the physiology point of view post PCI. This actually being evaluated in the IFR study, but you see that what we want, optimal, which is more than 0.9 FFR, is attained only in 60% of cases. And so, and these are the individual endpoints as you've seen here. No difference, angiography versus physiology. Rather, you can say, look at the angiography revascularization 10%, 16% with the physiology. So overall seems to be that there is no benefit, stent thrombosis and all shown here. So basically showing that 17% of the time, your FFR will be less than 0.8, and you do various treatments will be shown there. And of course, no matter what you do, you cannot completely normalize except in 8% of cases. And outcome at 2 years, you can see here 18% in each arm. So FFR or angiography guided. So basically showing that no benefit of routine angiography, the FFR or physiology post PCI. Then the VA system came up with that, what are the characteristic and outcome of the PCI which are ineligible for surgical revascularization. So they have a nice database, as we all know. The patients who are surgically ineligible deemed continues to increase from 6% 8 years ago to 19% now. And of course, median syntax score high. And then these are the regions. Ineligibility basically because of the hard team discussion, in majority of them, surgeons said, do the PCI. Just like case we have, do the PCI, and causes for the ineligibility on the right side shown, and anatomic and demographic, of course, they will be different. But most important is this slide. Mortality after PCI with the surgical ineligibility, you can see there is a difference of 4% mortality, 16.2 versus 12.1, almost p-value of 0.02. And if you add the MACE but mortality was there, MACE was 30.6 versus 27, p-value was 0.18. So if you take them, that patients, if you take mortality, definitely was lower in the surgically eligible patient versus ineligible patient. Mortality was higher. MACE rate and the repeat revascularization was not different. But if you basically match them, particularly in terms of the adjustment on anatomic and procedural characteristics, you can see the trend goes down. So, I mean, it becomes trend, no longer statistical significance in the mortality also. So basically 16.2 mortality versus 12.1. Unadjusted, adjustment decreased it further. So ineligibility of surgical revascularization was associated with increased risk of long-term mortality after PCI. The risk of adverse outcome after PCI, however, was similar among surgically eligible and ineligible patients after adjusting for major comorbidities like coronary anatomic features and procedural complexity. So basically, the last one is the ERCTO, procedural impact of the advanced calcific modification. We use many times the calcific modification devices and the calcific CTOs. The question is, does it make any sense? So this is basically the algorithm, CTO algorithm, which is very well populated. This is what they use. They use in the ER, European CTO, and basically showed here crossing strategy. Either you have the non-severe calcium, then you have advanced calcific plaque modification devices, or use of them or not use of them. You can see in the calcific lesions, in about 2/3 of the cases, you use advanced calcific, 75% actually, advanced calcific, did not use advanced calcific plaque modification. In 1/4, use the advanced calcific modification, and majority of those cases you go antegrade. Once you are using, of course, using these devices, your usually wire technique is antegrade. And there was not much different in IVL versus atherectomy, but definitely atherectomy more antegrade, because any dissection is a contraindication for atherectomy. So that's the reason majority of them with the antegrade. Second, Mackie. As you can see here, Mackie was the highest in these cases in the calcific, where you did not use this plaque modification devices, 4.1. Lowest was in the non-severe calcium, 1.8, and second group was 2.2, where you use these devices. And of course, you see the tamponade, also the lowest in the non-severe calcification, but whether you use a device or not, the tamponade was not different, so also the MI. And then this is the various types of perforations and atherectomy versus IVL, as well as in the advanced calcific plaque modification. As you can see here, in the calcific lesion, which is the center, if you did not use the advanced calcification, you have all kinds of perforations, but by using the devices, your perforation goes down. Very, very interesting. And also that the basically associate lower rates of overall perforation and target vessel perforation, and cardiac tamponade and cardiac tamponade perforation was least. And that is basically the cardiac tamponade is in the orange color. See the least in the non-severe calcium, then, but in the in calcific lesion, whether you use a plaque modification or no plaque modification, there was no difference in cardiac tamponade. So we learned quite a bit, and these are the usual CTO registry, and they put it together, everything what was noted in this study. So basically, conclusion was applying advanced calcific plaque modification devices in severely calcific CTO to PCI was associated with higher technical success and lower Mackie rate. The presence of severe coronary calcification or coronary angiography was marker of clinical and procedural complexity and was associated with technical failure, but not with the Mackie. So clearly, so the last one, again in the CTO line, what we have the latest data, where are we with the present and future of the CTO? And this was a very nice review article going through what the various techniques are. You have a wire, guide wire catheter, mother-child catheter. Make sure you take on a very nice views. So while we have all the advances for the CTO, they really emphasize the basic techniques of the CTO. Take your contralateral injection, take your good picture, make sure all the equipment you have, and go with the various techniques. And of course, where you particularly challenging cases of the prior bypass, the flush aorta or steel, bifurcation, LV dysfunction, and heavily calcified CTOs. And the algorithm is same to like which was shown earlier, that how to proceed with that, and basically showed that benefit and risk of the PCI of the CTO. Benefit is just shown that decrease in the symptoms and probably ischemic burden and may improve myocardial function, but has to be done by the experienced operator. That's a very important. So now CTO PCI is a class 2B according to latest ACHA guidelines, and very important, the risk could happen anything in terms of the bleeding and so on. There are some lesions, when they're complex, they're associated with a more problem. And then there are various CTO score for recanalization and CTO score for the MACE progress scores are used. Now, these are the 6 trials overall in nutshell, that CTO in a randomized trial, CTO PCI did not show any benefit. Whether improvement of EF, I know non-randomized trials have shown some data, but overall, no difference. Maybe a slight improvement in quality of life in the Euro CTO, but otherwise nothing there. And what they're also emphasizing, use of CTA. CTA can plan the what to do, which way to go, and to increase the success. And they actually have come up with a score. That with a CT, you have a score, CT reactor score calculator. Just like a JCTO score, based on the numbers that your success rate goes up and down. It also tells you about the which view you should be doing. So basically, to conclude, the CTO at present, success rate is upward of 90%, complication rates are less than 2%. While innovation is exciting and necessary, adhering to the basic principle of CTO, PCI, such as continuous assessment of risk benefit, meticulous angiographic review, and use of dual injection remains critical for achieving optimal patient outcome. And they actually say the AI may be very useful, particularly with a CTA prediction of success and complication. So CTO field continues to evolve. So let me just come back to our take-home message. Similar PCI outcomes after ultra-thin biodegradable polymer versus a durable polymer in multi-vessels, so supracruise versus Zions, exactly identical, no difference, but more importantly, pressaglol over ticagrelor in multi-vessel diabetic showed benefit. Second, the no benefit of physiology guided over angiography guided PCI, so thumbs down. Adverse outcome after PCI of surgically ineligible versus eligible VA patient because of higher mortality. Then improve outcome after plaque modification of calcific CTO PCI, absolutely yes. Then contemporary results of the CTO intervention have shown high success rate and low complication, contralateral injection, retrograde. Also, they emphasize that all operators, CTO operator who are skilled, high level should know the retrograde approach, because retrograde approach will add about 10 to 12% of your success. The introduction of newer equipment, especially guide wires and crossing catheter, and use of CTA and AI technology as a prediction tool have been beneficial. Despite these advances, implementation of basic technique of CTO PCI is essential to improve overall success safely. So 3 questions. Following are the true statement regarding the Tuxedo 2 trial. Comparing supraflex versus Zions. TVF was similar between 2 stents. MI rates were similar between 2 stents. TLR rates similar between 2 stents. Higher stent thrombosis in the supraflex and similar MACE rates between 2 stents. Clearly, we know stent thrombosis was identical between 2 studies. Second, recent publication from VA Health System regarding the outcome of PCI in surgically ineligible versus eligible patients showed the following, except patient deemed surgically ineligible are rising in last decade. Similar MACE rates between 2 groups. 30-day and 1-year mortality is similar between ineligible and eligible patients. Similar repeat revascularization between 2 groups. And mortality difference between 2 groups was attenuated after adjusting for target lesion and procedural complexity. Clearly, C is wrong because 30-day and 1-year mortality is not similar. It is higher in the surgically ineligible patient versus eligible patient. The last question, following are the true statement regarding the impact of advanced calcific devices, modified devices during PCI of the calcific CTO. Lowest MACE rates noted in the non-calcific CTO versus calcific. Similar anti-grade crossing strategy in non-ACPD versus non-advanced devices versus the using of device or not use of device, then higher revascularization after non-ACP versus ACP in calcium, then higher coronary perforation rates in non-ACP versus ACP, and coronary perforation tamponade is the least in non-calcified CTO and equal between ACP MD versus non-advanced calcific plaque modification. So basically the wrong is B. Similar anti-grade crossing strategy in non-ACP versus ACP, no, because basically if you do not use the advanced devices, this calcific plaque modification devices, you are going retrograde also. So higher anti-grade was used once you use to the advanced cross calcific devices. With that note, I'm going to stop here and we complete the presentation, and we'll go to Dr. Keeney Anu now to show us the final results and the imaging. Anu?
Okay, so we can go to the angiogram.
Angiogram
I think
first.
this is where we stopped. You see there, we have the LED wire. We did our, so compared to non-left main, when we did the LED diagonal, remember we never did the proximal optimization. That's what we have preach, and this is what is in our apps also. But in the left main, since there will be discrepancy between the LAD and the left main itself, 3.5 to 4.5, we did the part here. This is a 4.0. We went to 20 atmosphere. After that, we cross. Okay, you can see that same. How when you're crossing, you go to the optimal cell, and we'll show you in the imaging. By doing so, we never see any kind of crushed metal in the distal left main. So this was crossing with the fielder wire, just showing optimal cell. So once we do that, we took a 3.5, thinking that we didn't have to take, we were ready to actually do the anchor technique of the LAD, but the 3.5 non-compliant balloon went very easily into the circumflex. So we did the ostium of the circumflex with 3.5 20 atmosphere. Then we did the ostium of the LAD also. This was the kissing, and then we can show the IVUS. So this is the final picture we have.
And a lot of people will go with a report. I mean,
Yeah, we don't do that.
Yeah, we don't do it. Yeah.
Okay, so if we see here, this is the final of the circ, final of the LAD. EKG is good. Okay, Kiski,
But
show
what
us.
is that? What
Yeah.
there is still a very tight lesion. What is that?
So this is like a start of the like a distal circ. So we didn't touch here. So
Okay.
the edge of the stent is here.
Ah,
Distal edge on the plug.
So there is still some disease distally.
Yeah, yeah,
Distal.
there's
We
a
didn't
lot.
Very
cover.
calcific, yeah, but that's
Yeah,
fine.
yeah,
Yeah.
but stent is well expanded.
Wow.
And as Dr. Kenny mentioned, this is the level of the bifurcation, but like no residual mass, metal mass at the bifurcation. It's well modified and well expanded. Ostial circ is 8, distal left main is like 13, and the proximal edge is not coming to the ostium, but no major malapposition, no dissection.
But what is the LED? How is the proximal
Yeah,
LED?
we're going.
This is the circ, so that this is a final pullback. This is a pullback from the LAD. Actually, the mid part of the stent is 5.5. Still a lot of calcium behind, but it's more than 5.5. It's more optimal. And ostial LAD is well expanded.
Wow.
This is ostial LAD, like
Beautiful.
11. So yeah, well expanded stent, well modified.
Because remember, there is a little disease in the mid to distal LED, little disease in the OM, but you don't have to take care of everything. You are taken care of the main, Sutton's law. Take care where the main things are. And that is what was taken care of, was fantastic angiographic results and imaging results actually. We can go on to the camera now.
Samin, possibly the hardest case of the entire year and one of the hardest, I think, ever. Outstanding skills, Anu. Great demonstration. Nitin Barman needs to be thanked for sending us an outstanding case when the other case was cancelled. I also want to congratulate Upendra Kaul and Krishna Sudhir. I know how complicated and challenging. I mean, I call it the triple trial. They were trying to answer three questions in a single trial, but Anu, great job.
Thank you. And we see on the 200 next month, and we'll try to get some event. So next month will be about 2-3 hours of, we'll make it about 3-hour session of the episode number 200. We are going to invite few faculty. We are trying to look into it. And we'll make it a more didactic session, and some important few people, we want someone to come and be in the room, senior people we are talking about. So we'll really celebrate the 200th episode, which is, I mean, you can call it a Tour de France and whatever it is, to do a 200 episodes uninterrupted. 1 or 2 have been a little change of the date, but otherwise, same time, despite whether it's snow or not, we are able to do these cases. Fantastic.
Did not even interrupt during COVID.
Yep, that is correct.
We stop here. Anu, Samin, congratulations. Outstanding case. I want to thank our hugely interactive audience. We'll see you February the 17th.